Prophylaxis against venous thromboembolism in ambulatory patients with cancer. The risk of venous thromboembolism is 4 to 7 times as high among patients with cancer as among persons without this disease. Let's go to see a video about this.
Wolf. In this video, I'm continuing my series on acute care of oncology patients, and in particular, I'm focusing on oncologic emergencies, and I will be talking about venous thromboemboli in cancer patients. And why is this an oncologic emergency? Well, of course, venous thromboemboli can lead to pulmonary emboli, which can be a life-threatening condition. Now, interestingly enough, the incidence of venous thromboembolism in cancer patients has been reported in the literature in about 11 to 15% of cancer patients. But there are actually some studies that show on autopsy of cancer patients that up to 50% of patients have been found to have a DVT or a PE at the time of autopsy. So a DVT or DVT and PE are very common conditions that occur in cancer patients. Now, also, another fact that's important to note is that venous thromboembolism is the number 2 cause of death of cancer patients. Okay, so this is something, if you're taking care of cancer patients, this is something to consider. Now, also, on the flip side of that, it's important to remember that cancer is a common cause of DVT. So if you have a patient presenting with a DVT, then cancer should be on your differential. Now, what does that mean? That doesn't mean that I'm recommending that everybody that presents with a DVT needs an instant pan scan, but it does mean that if you have a patient that presents with a newly diagnosed DVT, you should have cancer in the back of your mind, and you should be asking those important history questions like, have you had significant weight loss? Have you had significant fatigue? Have you had a chronic cough? Have you had changes in bowel or bladder habits? Have you had any evidence of GI bleeding? Those other common signs and symptoms that we went over in an earlier video that patients with cancer commonly present with. So I'm just suggesting that you really sort of keep cancer in the back of your mind if you have a patient with a newly diagnosed DVT, because it is always a possibility. Now, I want to...
The venous thromboembolism is the second leading cause of death in patients with cancer, and overall mortality is increased among patients who have both conditions. It is a condition that includes both deep vein thrombosis and pulmonary embolisms. Deep vein thrombosis is the formation of a blood clot in a deep vein, usually in the leg or pelvic veins. The most serious complication of a deep vein thrombosis is that the clots could dislodge and travel to the lungs, becoming a pulmonary embolism. Let's see a video about venous embolism.
Animation shows how deep vein thrombosis, or DVT for short, forms. DVT is a condition where a blood clot forms in a deep vein, usually in the leg. Click the navigation arrows below the animation screen to play, pause, rewind, or fast forward the animation. The deep veins pass through the deep tissues of the leg. They transport blood from the legs and feet back up to the heart. The superficial veins lie below the surface of the skin. Here we show the position of the leg veins. The deep veins run between muscles of the leg. Contractions of these muscles when we move our leg and ankle help to squeeze the blood back up towards the heart. The veins also have valves that prevent the blood from flowing back towards the feet. DVT is where a blood clot or thrombus forms in a deep vein. It partly or completely blocks the flow of blood through the vein. A blood clot can form if a vein is damaged, if the flow of blood in the vein slows down, and if the blood has a higher than normal tendency to clot. Here we show the blood clot forming in the vein. Many blood clots are small, and your body will usually be able to gradually break them down. Here we show a small blood clot being broken down, and the blood flow through the vein returned to normal. Sometimes a larger blood clot can form. A larger clot can completely block the flow of blood through the vein. Here we show the blood clot growing larger. A large blood clot may cause pain and swelling in the affected leg. However, DVT doesn't always cause symptoms. This is the end of the animation. Click on the animation screen to watch.
The risk is highest for patients with certain types of solid tumors and hematologic cancers, and is increased for patients who are receiving chemotherapy or radiotherapy, who have undergone operative procedures, who have metastasis disease, or who have inherited thrombophilias. Studies have indicated that mechanisms of this effect may include mucin production by tumors, exposure of tissues, factor-rich surface, and tissue factor-bearing microparticles, cysteine proteins production leading of thrombin generation, and local hypoxia. Let's see this short video about cancer and thrombosis.
The low molecular heparins have been evaluated in a number of settings in cancer patients, both for the prevention of primary venous thromboembolism, this is in thrombosis in patients undergoing elective surgery, or cancer patients admitted to hospital with acute medical illness. Low molecular heparins such as dalteplin and enoxaparin have been evaluated in those settings and form part of the guidelines in the United States, both NCCN and ASCO, recommending routine thromboprophylaxis for these two populations. But the low molecular heparin dalteplin has also been extensively evaluated in a single but large clinical trial, the CLOT study, with regard to the potential to prevent recurrent thromboembolism in patients with the first episode of deep vein thrombosis or pulmonary embolism. In the CLOT trial, we randomized 676 patients with proximal DVT, PE or both, and active cancer, defined as cancer within the last 6 months or active cancer therapy, to a standard therapy arm where patients received dalteplin for 5 to 7 days in full treatment doses, followed by oral anticoagulant vitamin K antagonists for a further 6 months with a target INR of between 2 and 3, or the experimental arm, which was dalteplin for 6 months, 1 month of full treatment doses of dalteplin, followed by 5 months of 75% of the full treatment dose of 200 international units per kilogram. And the study provided a fascinating result. It demonstrated at the end of 6 months a 52% reduction in the rate of symptomatic recurrent venous thromboembolism in favour of patients randomized to receive 6 months low molecular heparin therapy with dalteplin to prevent their recurrent venous thromboembolism. In terms of bleeding associated with therapy, there was no significant difference in bleeding rates. 5.6% of patients in the dalteplin group had a major bleed, compared to 3.6% of patients receiving a vitamin K antagonist, not statistically significantly different. And in terms of any bleed, there was no significant difference between the two groups. So overall, guidelines, both ASCO and NCCN, adopted long-term low molecular heparin therapy with an agent such as dalteplin as a preferred choice for preventing recurrent thromboembolism in patients with established cancer-associated thrombosis.
The use of prophylactic anticoagulation therapy in most hospitalized patients with cancer and in patients undergoing surgery for cancer has been understood despite limited data. Empirical prophylaxis against venous thromboembolism in ambulatory patients who have cancer remains controversial. The largest studies of prophylaxis against venous thromboembolism, the prophylaxis of thromboembolism during chemotherapy trial and the SAFE-ONCO study showed decreased rates of events among patients who were receiving chemotherapy for cancer. Smaller studies involving select patients at the highest risk for venous thromboembolism, such as those with pancreatic cancer, have shown a greater magnitude of decrease in venous thromboembolism with the use of the prophylaxis. The increase of prophylaxis against venous thromboembolism in high-risk ambulatory patients with cancer who are eligible for this therapy could lead to improved outcomes. Further studies are needed to assess the effects of this prophylaxis on morbidity, mortality, and the cost of care for patients with cancer. Sorry. Now let's going to see the
Recently
last
saw
video.
a patient from Poole in Dorset who came to see me on thrombosis, wondering whether he needed any tests. Well, he was in his 60s, so I had some unpalatable news for him. As his deep vein thrombosis was unprovoked, he should have tests to check that he doesn't have cancer. So what exactly do I mean by unprovoked? Well, this is a deep vein thrombosis that comes apparently out of the blue. That means that in the preceding 3 months before the development of the deep vein thrombosis, there's been no evidence of major surgery, major trauma, there's been no immobility, so the person hasn't been bedridden or spent a significant part of the day either in bed or in a chair. The person is not pregnant, and the person is not taking hormone replacement therapy or the oral contraceptive pill. Now, if a deep vein thrombosis is unprovoked and the person is under 40, then they should have, as a bare minimum, a full examination, a chest x-ray, some screening blood tests, and their urine should be analysed. Now, if the person is over the age of 40 and has an unprovoked deep vein thrombosis, then they should be fully investigated for cancer. And that means a mammogram in a woman, and in both men and women, a CT scan of the abdomen and pelvis. Now, I don't want to cause alarm, but approximately 10% of people who have an unprovoked deep vein thrombosis then find that they have a cancer within the next 12 months. Now, they probably had the cancer, it's only just become apparent with time. And
I hope this video will be useful to you. Bye.